Welcome back to the deep dive. Today we are focusing on a clinical reality that sits in the background of almost every oncology clinic, and yet it often goes undermanaged until it's far too late to really intervene.
How?
We're talking about the patient who is literally starving to death in a world overflowing with calories. You know, the patient I'm talking about, advanced gastric, maybe pancreatic cancer, weight just dropping off despite your best supportive care efforts.
It really is the paradox of the starving host. And we're not talking about simple malnutrition here. This is something else entirely. We are dissecting cancer-related anorexia cachexia syndrome, or CKS.
The stakes are just incredibly high, and I think we sometimes become desensitized to it because we see it so often. But looking at the data for this dive, especially for gastrointestinal malignancies, the prevalence hits up to 80%.
80%. And even more disturbing is that cachexia is the direct cause of death in 20% of cancer patients.
That distinction is so vital right off the bat.
It is. Many patients die with cachexia, which sort of implies it's just a feature of the dying process. But 1 in 5 die of it. The metabolic failure itself kills them before the tumor burden does.
We're talking respiratory muscle failure, immune collapse.
Cardiac atrophy. It's a total system failure.
So to navigate this, we're pulling from two heavyweight sources today to try and standardize our approach. First, we have the 2023 clinical guidelines from SEOM, the Spanish Society of Medical Oncology.
And they give us that really solid structural framework for definition and staging.
And then to shake up our pharmacological approach, which, let's be honest, hasn't changed much in decades, we're layering in a 2024 meta-analysis on Megestrol acetate.
Right, published in the Journal of Cachexia, Sarcopenia, and Muscle. And this paper, it really challenges some very old prescribing habits, specifically on dosing.
So our mission today is pretty straightforward. We want to move past the generic advice of try to eat a little more protein or drink this shake. We want to equip you with specific staging criteria, the nutritional protocols that actually work, and the nuanced dosing data that might change how you write your next prescription. So let's start with the biology. Why is CACS so different from just starvation? If a healthy person stops eating, they adapt, right?
Right. A healthy body is incredibly smart. In simple starvation, say famine or fasting, it adapts to conserve energy. It turns down the metabolic thermostat.
Slows the heart rate, all of that.
Exactly. And it prioritizes burning fat stores to preserve the vital protein in your skeletal muscle. It's a survival mechanism designed to keep you moving until you find food.
But in CACS, the rules change completely.
Completely. It's what we call metabolic coup d'etat. The tumor hijacks the host's entire energy regulation system. You get this massive release of pro-inflammatory cytokines.
The cytokine storm.
Cytokine storm, yes. Tumor necrosis, factor alpha, interleukin-1, interleukin-6.
And this storm forces the body into, what, a permanent state of high alert.
A permanent state of high alert. You see increases in hormones like glucagon, cortisol, catecholamines. But the real metabolic tragedy is the switch to neoglycogenesis,
Which is just incredibly inefficient.
It's arguably the most inefficient way to produce energy. The body starts breaking down protein, your skeletal muscle, to create glucose.
It's like that analogy of burning the furniture to heat the house.
It's exactly that. Simple starvation is turning down the heat to save gas. Cachexia is chopping up the antique furniture to keep the fireplace roaring, even when there's a stack of firewood right outside.
And that chopping up the furniture is proteolysis.
Yes. The ubiquitin proteasome pathway gets activated. It literally disassembles skeletal muscle fibers to fuel this metabolic fire.
Which is why you can't just feed your way out of cachexia.
You can't. You can pour calories in, but if that metabolic drive is still chopping up the furniture, the patient will still lose muscle mass.
This is why catching it early is the only real strategy. And the SEOM guidelines really emphasize staging. They don't just lump everyone into cachectic.
No, and for you as the clinician, this stratification is the difference between an intervention that works and one that's just futile. They break it down into 3 stages. First, you have precachexia.
This is the invisible stage,
Right. Often, yes. It's defined as weight loss of less than 5%, but, and this is key, it's accompanied by early metabolic signs.
Like glucose intolerance or anorexia.
Exactly.
Yeah.
The patient might look normal, but their biochemistry is already shifting. This is your window of opportunity. If you intervene here, you can stabilize them.
Then we move to establish cachexia.
And this is where the numbers become undeniable. Weight loss greater than 5% over the last 6 months. Or if their BMI is already less than 20, a weight loss of just 2% puts them in this category.
And sarcopenia plays a role too.
Right. If they have sarcopenia measured muscle depletion, that same 2% loss triggers the diagnosis. At this point, Systemic inflammation is usually rampant.
And finally, the stage every oncologist dreads, refractory cachexia.
This is characterized by irreversible catabolism. The patient usually has a low performance status ECOG 3 or 4 and a life expectancy of less than 3 months.
And the guidelines are pretty clear here.
Very clear. Aggressive intervention at this stage is not just unlikely to succeed, it's often ethically complex. The burden of treatment just outweighs the benefit.
We'll circle back to managing that refractory stage, but sticking with diagnosis, you mentioned precachexia often isn't visible. I think this is a huge blind spot for us. We see patients who are overweight, and we assume they have nutritional reserves.
That is such a dangerous assumption. We're seeing a huge rise in what's called sarcopenic obesity. A patient can have a BMI of 30, but have severe muscle depletion hidden underneath adipose tissue. If you just eyeball them, you will miss it.
Which is why the guidelines insist on validated screening tools.
Yes. They mention MUST and MST. The MST malnutrition screening tool is particularly good for an outpatient clinic because it's so fast.
Just a couple quick questions.
Right. Recent unintentional weight loss and decreased appetite. It's a low barrier to entry for a busy nurse or PA.
But the guidelines highlight one specifically for oncology, right? The Nutri-Score.
Yes, Nutri-Score is specifically validated in oncology. It's a bit more comprehensive. It looks at weight loss and appetite, sure, but it also factors in tumor location and treatment toxicity.
So it helps you triage who needs a dietitian right away.
Precisely. It classifies patients into risk or no risk.
Beyond the questionnaires, though, we have blood work. We're all ordering labs anyway. What are the biochemical flags that should trigger a cachexia workup in my brain?
You are hunting for systemic inflammation. High C-reactive protein, or CRP, is the classic marker. But also look at albumin,
Hypoalbuminemia.
a major indicator of poor nutritional status and inflammation. And don't ignore unexplained anemia.
Right, so if I see anemia and low albumin, even if the patient's weight is stable.
Alarm bells should be ringing. That stability might just be fluid retention masking the muscle loss. You need to look closer.
Okay, so we've screened them, we've staged them, now we need to treat them. The SEOM guidelines outline a step-up approach. I think the tendency is to jump straight to the heavy artillery.
TPN or high-dose steroids, because we want a quick fix. And that is a fundamental error. Skipping steps usually leads to failure. The foundation, step 1, is dietary counseling combined with oral nutritional supplements.
It's the combination that matters, isn't it?
It is the only thing that matters at this stage. The data is brutal on this. Handing a patient a prescription for a supplement drink, those high-calorie shakes, without professional dietary counseling is largely ineffective.
They get flavor fatigue.
They get flavor fatigue, they get early satiety, they stop taking them, or they use the shake as a meal replacement so their total caloric intake doesn't actually go up. Counseling is what drives adherence.
Okay, so let's say we do that. Counseling, shakes, optimizing intake. But the patient has a mechanical issue, maybe an esophageal tumor. We move to step 2.
Enteral nutrition. If the gut works, use it. Tube feeding NG or PEG is physiologically superior to intravenous feeding. It preserves the gut mucosal barrier, maintains the microbiome.
And has fewer infectious complications.
Way fewer. Which brings us to the controversial one. Step 3. Parenteral nutrition. PNE. The SEOM guidelines seem to draw a pretty hard line in the sand here.
They do. And for good reason. TPN is not benign. It carries risks of catheter-related sepsis, thrombosis, metabolic imbalances. The guidelines state it should only be considered if the gut has failed.
And this is the crucial qualifier. If the prognosis is greater than 2 months.
That 2-month prognosis is the cutoff.
Generally, yes. If the life expectancy is less than 2 months, the risks and the loss of mobility from being tethered to a pump usually outweigh any potential benefit. You're not going to reverse catabolism in that time frame.
So if we are feeding them, what are the targets? We often just say high protein, but what does that actually mean?
We aim for a total energy expenditure of about 25 to 30 kcal per kilogram per day. But you're right, the protein is the headline. We need 1 to 2 grams of protein per kilogram per day.
That is a massive amount of protein for someone with no appetite.
It is. A 70-kilo man needs up to 140 grams of protein. That's why the supplements are so necessary. We're trying to flood the system with amino acids to counteract that breakdown we talked about.
Before we leave nutrition, I have to ask about the magic bullets. Patients always come in with bags of supplements. Omega-3s, H&B.
It's a mixed bag. Omega-3s are safe, and the anti-inflammatory theory makes sense, but the clinical data is pretty heterogeneous. It's a maybe, not a mandate. H&B has stronger evidence, specifically for preserving muscle mass.
And those expensive immunonutrition formulas?
In the surgical setting, maybe? In chronic cancer cachexia. The SEOM guidelines are clear. There's virtually no evidence to support them. Save the patient's money, stick to calories and protein.
Okay, let's give it to the pharmacological side. This is where I think practice patterns vary wildly. We have the old guard steroids, dexamethasone.
The double-edged sword. Steroids are excellent for a quick kickstart. They centrally stimulate appetite and give us the sense of euphoria, but that effect is very short-lived, a few weeks usually.
And the long-term cost?
Myopathy. Steroids cause muscle wasting. So if you keep a patient on dexamethasone for months to help their appetite, you are actively worsening their sarcopenia. It's totally counterproductive.
So short-term use only. That leaves us with the progestins, Megestrol acetate, or MA. It's the standard of care in a lot of places. But this 2024 meta-analysis you brought, it really complicates things.
It does. This analysis looked at 13 trials, over 1,200 patients, and the headline finding forces us to check our assumptions. When they compared Megestrol acetate to placebo, there was no significant increase in body weight overall.
Wait, the drug we prescribe specifically for weight gain doesn't actually increase weight?
Not across the board. But when they drilled down, they found a linear dose-response relationship. So for every 200 milligrams per day increment, weight gain increased by about 0.4 kilograms.
So the logic would be more is better.
Not quite. This is where the art comes in. They identified a sweet spot. The greatest efficacy to the safety ratio was observed at 320 milligrams a day.
320, because I've definitely seen prescriptions for 800 milligrams.
And that's common practice. But the study showed that when you push the dose up to 800, you don't see a proportional benefit in weight. What you do see is a spike in toxicity.
Thrombosis,
edema, adrenal suppression. These patients are already hypercoagulable. Pushing a prothrombotic drug at high doses for diminishing returns is just bad medicine.
So 320 milligrams is the target. But I want to clarify something about this weight gain. What exactly are they gaining? It's not muscle, is it?
No. And we have to be brutally honest with ourselves and our patients about this. The weight gained on Megestrol acetate is adipose tissue, fat, and fluid. It is not skeletal muscle.
That feels clinically hollow. If the enemy is sarcopenia and we're giving a drug that just adds fat and water, are we actually helping?
That is the central paradox.
Yeah.
Biologically, no, we aren't fixing the muscle wasting. However, and this is a massive however, the meta-analysis found something else. Even though the weight was fat and fluid, the patients reported a significantly improved quality of life.
The EORTC scores.
Exactly.
Yeah.
The QLQC30 scores went up significantly.
Yeah.
The patients felt better, their appetite improved, their distress about eating decreased, their social enjoyment of meals came back.
In palliative oncology, subjective improvement is a valid clinical endpoint.
It's a huge endpoint. If a patient is distressed because they have no appetite and this drug relieves that distress, that is a win, even if we're just putting on a little fat.
So we aren't curing the cachexia, we're managing the symptom burden.
Correct. And timing matters too. The meta-analysis showed MA works best in the short term, less than 8 weeks. So the strategy is, start at 320 milligram, monitor for edema, and reevaluate at 8 weeks. Don't just put it on the med list and forget it.
Are there any other contenders? Everyone asks about cannabis.
The SEOM guidelines are pretty ruthless here. Cannabinoids. The evidence is weak, and some studies actually advise against it due to side effects like somnolence or confusion.
And anamorelin, the ghrelin agonist.
It shows some promise for increasing lean body mass, unlike Megestrol, but it hasn't consistently translated to improved functional muscle strength, so it's still in the investigational bucket for most guidelines.
So we're back to the basics. Screen early, counsel plus ONS, and judicious use of Megestrol acetate at that 320 milligram dose for symptom control.
That is the current gold standard.
We have to address the end of the line, the refractory stage. We said the strategy has to pivot here. This is often the hardest conversation for us, and even harder for the family.
It is. When a patient enters refractory cachexia, catabolism is rampant. Performance status is failing. Continued aggressive feeding is not just useless, it can be harmful.
I think there's this huge misconception that food is love and that withholding it is cruel.
That's the cultural barrier we fight.
Yeah.
But physiologically, forcing calories into a body that can't metabolize them leads to nausea, vomiting, abdominal distension, increased bronchial secretions.
You're essentially overloading a system that is shutting down.
Exactly. At this stage, the goal shifts entirely to comfort. The SEOM guidelines are explicit. Discontinuing parenteral nutrition or aggressive feeding near the end of life is appropriate. It reduces symptom burden.
It's moving from treating the number on the scale to treating the person in the bed.
We stop worrying about calories. We focus on food for pleasure. If they want ice cream, they get ice cream. If they want one bite of soup, that's fine. Good mouth care, managing thirst. That is compassionate management.
It's a sobering reality. So let's wrap this up. If you're heading in a clinic tomorrow, what are the 3 big takeaways?
First, screen early. Don't wait for the patient to look cachectic. Use the MST. Catching it in the Precachexia stage is your only real shot at stabilizing the metabolic decline.
Second,
Nutrition requires a team. A prescription for a supplement shake is not a treatment plan. It must be paired with dietary counseling. And use the gut if it works. TPN is a last resort.
and the third from our pharmacological deep dive.
Dose matters. If you use Megestrol acetate, aim for that sweet spot around 320 milligrams a day. Understand that you are treating appetite and quality of life, not muscle mass. Pushing the dose higher will just get you more toxicity.
It's a shift from bulk them up at all costs to optimize how they feel.
That's the mission.
I want to leave everyone with a thought to mull over. We've established that the drugs we have, like Megestrol acetate, improve quality of life scores but don't actually fix the biological problem, the sarcopenia. They gain fat, not muscle.
Right.
So, if we are prescribing these drugs, are we treating the cancer syndrome? Or are we treating the patient's and maybe the family's perception of their decline? Is seeing the number on the scale go up, even if it's just fluid and fat, a kind of placebo for the psyche, and in palliative care, does that difference even matter?
That is the ultimate question. If the patient feels better, maybe the biology is secondary.
Something to think about the next time you write that prescription. Thanks for joining us on this deep dive.